the fat which is getting deposited around the liver, around the central axis of liver resistance. So in a patient with a liver resistance, as he consumes more, the triglycerides or the fat gets deposited in the liver. Once it gets deposited in the liver, the excess of fat which is getting deposited around the liver gets spilled over to the pancreas also. So the extra amount of energy that is getting deposited as fat in this patients can get deposited not only in the liver, can get deposited in the pancreas also. So can we just take all this fat away from these individuals and make them as normal? So if these patients are because of extra consumption of carb or fat, if they are prone for diabetic, can we just take away all these things and can the patients become normoglycemic, or can the reversal of diabetes be achieved in these patients? So that's what he showed in this beautiful article, where he said by reducing the consumption of carbohydrates to less than 800 calories. So 800 calories is very, very difficult. Typically, like we take about 700 to 600 calories for a meal. So by reducing the entire consumption in a day to reducing it to 800 calories, we can reverse the diabetes, because the accumulation of fat which is happening in the liver, in the pancreas, the spillover that happens in the pancreas can be reversed when we take less consumption of alcohol, and the fatty liver also typically regresses. So what is important is the consumption of extra calories is the one that makes these patients prone to fatty liver. So that is the number one point why the patients may have a fatty liver. So the number one point is obesity or the extra consumption of carbohydrate. The second thing is de novo lipogenesis. So de novo lipogenesis means, so the fat that is getting deposited or generated in the liver, the 5% of the fatty acids come from de novo lipogenesis, from the carbohydrate, from the simple sugars, the fat gets generated. So in a patient who is prone for fatty liver, 25% of this can come in the presence of insulin resistance, can come from carbohydrates. So what we mean to say is, in a patient with insulin resistance, if the patient doesn't have an insulin resistance, 5% of his simple sugars can get converted to fatty acids. So in the patients who are prone for fatty liver, 25% of these carbohydrates can get converted to fat, and they can get deposited as triglycerides in the liver. So the insulin resistance and these patients are more prone for deposition of fat. So this is de novo lipogenesis happening in these patients. So there are 2-3 points that we need to know in this background. Like in one particular study, what they have done is they tried to substitute. So the patient takes isocaloric diet. So if the patient is taking 2000 calories per day, they tried to replace whatever coming from the fat with carbohydrate. So they replaced same, but the calories were maintained same. So 2000 calories, instead of coming from a mixed meal with carbohydrate and fat, they in a subset of people, they tried to make the calories coming only from the carbohydrate. So in these set of people who were consuming only carbohydrates, their synthesis of conversion to fatty acid was much higher. So the point that we need to drive is, it is more than fat, it is a carbohydrate which is essential for de novo lipogenesis, and they are more prone for deposition or the production of triglycerides, and these triglycerides are the one which gets deposited in the liver. Very, very important. So it is not the fat that directly causes this, it is the carbohydrate which is much prone. Yeah, and in another particular study, what they have shown is the patients were fed for 21 days on a high carbohydrate diet. So 1000 calories, they increased the consumption by carbohydrate. So at the end of the study, in 21 days, the synthesis or the deposition of triglycerides was much higher, even by increasing 1000 calories per day just for 21 days. This study was just for 21 days. 3 weeks when the calorie intake was increased by 1000 calories, the deposition of triglycerides was increased by increasing it by 1000 calories just for 3 weeks. So it is very, very important that what we consume as is important for the deposition of triglycerides, and most of it comes from the carbohydrate rather than from the fat. So consumption of carbohydrate, if it is higher, it may predispose the individual to fatty liver than the consumption of fat per se. So that is very, very important. That is important therapeutically also, which we will see later. The third thing is, I was keep telling, like, people who are predisposed to fatty liver. What do we mean by predisposed? Predisposed individuals are the one who had this PNPLA3 gene polymorphism, which was encoding for this allele 148M. So when these gene polymorphism patients were there, so there are some genome-wide association studies, typically around 2010-12, they did some genome-wide association studies. In all these studies, they showed when these people were having this PNPLA3 gene polymorphism, they were more prone for developing fatty liver and the complication was higher. And not only the genome-wide association studies, there was a meta-analysis which was published in the year 2012, which culminated the data of about 16 studies or so. What they saw in this study was, when they had this PNPLA3 gene polymorphism in these patients, typically, like, when they were predisposed or when they were having this gene polymorphism, they were associated with 70% increase in these people were predisposed to fatty liver, 70% increase in fatty liver. And the risk of necrosis or inflammation was increased by 3.2 times when this genetic defect was present. So 3.2% of necroinflammation alone, the individuals are predisposed. Not only the necroinflammation, also the fibrosis was also increased by 3.3 times. So when this defect was there, they were more prone, like they were 3.3 times more prone to get fibrosis and necrosis. So, which is very, very important that genetics also plays a role. So, the reason why people develop fatty liver is, one is obesity and what we consume, and de novo lipogenesis, which comes more from the carbohydrate, and genetics has a huge role over here. So, we need to understand these three things which can predispose the individuals for a fatty liver. Having known that, what is the definition for